Thank you, everyone, for this opportunity. Thank you, Dr. Pandav, for the introduction. So, I have been asked to talk about different angle to managing acute angle closure. What are the different modalities that could be possible? No financial disclosures. Now, we all know that angle closure disease is a spectrum going from angle closure suspect all the way to angle closure glaucoma, which can be initially medically controlled and then remains uncontrolled and causes more progression. And at all these spectrum of the disease, we can encounter acute angle closure. Now, if it remains on this in the spectrum where there is no acute angle closure, the morbidity is slightly different from than when there is acute angle closure as an event happening. Now, etiology for angle closure disease, of course, pupillary block, angle anomalies, lens factors, and behind the lens factors. So why discuss this? Because acute angle closure can cause significant morbidity over time. In about 60% of people, people require medications within 5 years, and about 35% eventually require trabeculectomy. The idea is to prevent visual loss from high pressure episode that can happen, and also to prevent progression to angle closure glaucoma if that's not already been present. And over a 4 to 10 year period post acute angle closure, data shows that 18% of patients can go blind, about 50% will have significant glaucomatous optic neuropathy, and about 60% have a fall in vision as well. So the principles of treatment are to primarily reduce pressure as quickly as possible, to reduce the inflammation, and also to reverse the pupil block and open the angle as much as we can. The goals of treatment are also to prevent risk of damage to the anterior segment, reduce risk of optic nerve head damage, and also to prevent recurrent spikes in pressure. So lowering the IOP will reduce the corneal edema. There's a conventional medical method and laser iridotomy, whereas there are alternative methods like anterior chamber paracentesis, ALPI or pupilloplasty, corneal indentation, supine positioning, and corneal scraping, which have been tried to a certain extent. Now, IOP reduction is done medically with our known entities, and this will allow us some corneal clarity. And then eventually that is followed by laser iridotomy. And always remember, we've seen so many patients who come in with the acute angle closure eye having had laser iridotomy, and the practitioner has not done laser iridotomy in the fellow eye. This is literally a crime, because about 50% of people who have acute angle closure in one eye can have, the risk is like almost doubled in the other eye. And it's important to remember always to treat the fellow eye as at some point and not forget about that eye till that eye gets an acute attack. Now, like I mentioned, various methods have been tried. So studies have shown the reversal of acute angle closure episode within the first 24 hours happens in almost 90% of patients, and about 22% over 3 hours, and about 50% at 6 hours, and about 80% in about 12 hours. Complications and side effects are relatively low. In about 2.2% patients, it fails to resolve and requires surgery at some point. Now, laser iridotomy remains the treatment of choice at this point in time. It's relatively non-invasive, easy to perform, low risk of complications. There are a few issues like bleeding and hyphema in an inflamed iris. Some IOP spike post-laser, the LPI might close soon after that, and there can be rarely corneal decomposition that was reported earlier but not seen anymore, because I think we have become more sort of attuned to using the right amount of laser power and the right techniques. Now, methods and effectiveness can vary by race, and in non-pigmented irides, the YAG capsulotomy alone may work better, whereas in pigmented sequential argon YAG capsulotomy, iridotomy may be a better approach, where we actually trench the iris first with argon laser and then use YAG to open up the trenched part of the iris. Now, Caucasian eyes, LPI alone seems to be sufficient in controlling intraocular pressure in about 70% of patients. And additional medical therapy can control patient IOP in about 84 to 99% of patients. Whereas in Asian eyes, LPI alone manages to control pressure in about 35%, and about 60% require use of additional IOP medications over time, or even glaucoma surgery. Now, relieving pupillary block, LPI is the best and the best approach. And if you look at data, they've shown that about 60% eventually need drops, and about 35% require surgery at some point. And a smaller study showed that about 100% ended up requiring drops over 63 months, and about 60% required surgery. Now, corneal edema and poor visibility could be a challenge when you have laser iridotomy in an acute angle closure eye. Bunched up iris can cause poor penetration and bleeding. There's more pigment dispersion, of course. Patients can be poorly cooperative due to all the systemic conditions, pain that he's suffering, and couple of sittings might be required. Now, the problems with medical management, of course, there are systemic contraindications patients may have to medications. Also, risk of systemic complications with the medications in the form of metabolic acidosis, electrolyte disorders, and congestive cardiac failure if patients can be contraindicated if and can't use mannitol if at all. And there are eyes that are refractive to this as well. So some angles open up after laser iridotomy, some don't. And there are multiple reasons for it. So if we can't, what are the other alternatives? Iridoplasty and AC paracentesis have been tried, and then further going on to lens extraction and goniosynechiolisis or trabeculectomy. Now, ALPI or argon laser iridoplasty causes contraction burns to the peripheral iris, and this sort of pulls the iris away from the pupillary area and allows us to reduce pressure. Now, it allows good IOP control initially, good reduction in intraocular pressure in eyes which are sort of not amenable to laser iridotomy on the table, and allows to sort of reduce PAS in some to a certain extent. And versus medical management, however, no long-term significant differences were noted. And there are issues with efficiency which is lesser when there's already pre-existing PAS, and there's also a learning curve, and it's also again tricky in cloudy cornea. Now, typically indicated when corneal edema persists or anterior chamber is very shallow to allow a safe iridotomy, and this pulls the, as I mentioned, pulls the angle open away, facilitating some aqueous drainage. Now, in about 70 eyes, I would attempted to do acute angle closure, initial treatment with timolol, pilocarpine, randomized to iridoplasty versus medications, no significant difference in mean IOP or need for medications or extent of PS between the two techniques. It is a safe and effective alternative in medical management of acute angle closure. If you look at the cons, like I mentioned, you can have corneal abrasions and corneal endothelial cell damage because of the fact that sometimes the ACs are so shallow. Persistent mydriasis can be a challenge in some patients, peaked pupil, and it technically does not eliminate pupillary block because you're actually treating one small segment of it. Anterior chamber paracentesis conceptually evolved as a path to sudden reduction, rapid reduction in intraocular pressure, similar to indications as iridoplasty, and if there is lack of access to immediate laser therapy, and controlled range of aqueous from anterior chamber by a needle or a 15-degree blade. Now, technically challenging, AC shallow can cause trauma, it can cause bleeding, and rapid decompression can cause suprachoroidal hemorrhage and retinopathy and hyphema, aqueous misdirection in rare instances, and the risks that are inherent to any intraocular procedure. So it showed that IOP started to rise towards to levels that were comparable to medical treatment soon after patients were subjected to paracentesis. However, I think in the literature for this approach is limited, and the benefits of paracentesis appear very short-lived. It's an invasive technique. Asepsis is always a challenge. Patient cooperation is important, and you need to follow it up with the laser iridotomy as early as possible or attempted. And potential risks of infection, decompression remains a concern. So pupilloplasty is also another temporizing measure that's been tried. Corneal indentation using muscle hooks or gonioprism or cotton tip applicator or glass rods have been tried. Again, all these are short-lived, immediate relief, but for the corneal edema to be clearing up faster and makes it easier to sort of then perform laser iridotomy at an earlier stage if that's the case. So which angles? So lens also, a large lens can also play a significant role in sort of the final outcomes of acute angle closure. And the benefits of cataract surgery in residual angle closure remains after LPI. The lens extraction allows for relief pupil block, reduces crowding, and widens the drainage angle. Multiple studies have shown significant benefits in cataract extraction versus LPI. However, cataract surgery in acute inflamed eye is challenging. Inflamed eye this can cause and the view is poor due to corneal edema, higher risk of endothelial cell loss, floppy iris, small irregular pupil, and higher risk of intraoperative complications. And there's also a temporal time relation from acute angle closure to surgery. So cost effectiveness may be an important factor to consider. We can also consider synechiolisis. Phacoglaucoma synechiolisis for effective IOP control has been attempted and has found to be quite effective. Phacotrabeculectomy and trabeculectomy are rarely sort of indicated in some instances and has been shown to have fairly good success. So, however, the role is limited because of the high risk of surgical failure and complications in an inflamed eye and may not be the initial treatment of choice. So, to summarize, medical management followed by LPI still remains the procedure of choice for acute angle closure as the first approach. Iridoplasty lens extraction, alternative methods that can be tried. Synechiolisis is a useful adjunct to manage PAS, and filtration surgery if there is clear evidence of extensive synechia with advanced glaucomatous cupping. The cost-benefit ratio and life expectancy also has to be considered when we look at the different approaches to manage acute angle closure. Thank you.
Thank you, sir. So, any comments or any questions you would like to ask Dr. Rajesh? I think Dr. Rajesh, many times, when the acute angle closure, the attack which is of a recent onset, in a few hours or maybe a day, that's a little kind of easier to manage. But once you have, is a delayed or it's not recognized early enough, and you have a lot of inflammation and other tissue damage occurs. So how can you kind of deal with those situations
I think, irrespective of where we practice, I think access to an ophthalmologist still remains a challenge. And the time of presentation, like you said, from the time the acute attack happens, irrespective, I think all of us will agree that laser iridotomy is not something that has not been achievable in most patients as a first step in management. And, the medical management that preempts that before we do the procedure. It's very rare that we don't manage to succeed with this. The only challenge, of course, is the amount of laser we have to use in some instances if the iris has been inflamed for a while and the bleeding that happens from multiple shots. So you would think that you would try and do a laser at one spot. If it's leaking or bleeding, sometimes it is best that you put pressure with the lens, sometimes even give the patient a break, wait for that to clear up and attempt again, instead of trying to keep on shooting multiple times through the bleeding iris.
Doing laser iridotomy is actually quite difficult once you have the iris is inflamed, and you end up releasing more pigment and increasing inflammation. Basically, it could actually make it worse. So the surgical iridectomy would be better option there.
Yes. It's invasive, so that's something that we'll have to, if it's that sort of situation, I would think that if there is a cataract, there is a clear opportunity to think about cataract extraction, but definitely not clear lens extraction. I don't think that's there's no evidence for that, at least.
Cataract surgery in the acute phase is actually difficult.
Yes, it's very challenging.
It's challenging and is more prone to have develop complications.
Very experienced, that wouldn't be something you want to attempt.
So do you consider like decongesting these eyes with some IV mannitol?
So mannitol, IV Diamox,
some topical steroids and make the eye.
Steroids all help to bring it down effectively.
So if you're successful in reducing the pressure initially, I think that gives you time to plan. Then you can actually wait for a little while, let the eye settle down. Maybe certain hours or days, and then you could do laser iridotomy or something.
Even worthwhile waiting for. If you break the acute attack medically, it's even worthwhile waiting for a day or two before you do the LPI. It doesn't hurt.
Thank you, Dr. Bhattacharjee, for joining us, and welcome to this session. Yeah, Dr. Bhattacharjee has a question.
I want to know your best recommendation for a type of patients. So one of my patients, he traveled by air and he underwent vitrectomy surgery with C3 effect gas. Now, While the flight took off, after some time he developed severe pain and loss of vision. So when he landed, the doctor over there, of course he was not he did not comply with our advice. So he advised to come back by surface. So 3 days over. The patient came with a intractable pain in the eye, bouts of vomiting, completely flat anterior chamber, there is inflammation, and inflammatory exudates are there in the anterior chamber. What will be your line of management in this type of patients?
So it also depends on whether a patient had silicon oil in the eye.
No, guess, C3F8 guess.
So the silicon oil itself could be causing.
No, not C3F8, no silicon. C3F8 guess.
C3F8, okay. So we have to break the pressure attack in the first place, medically if possible. You obviously can't try and and you also have to think about why this is sudden flattening of the anterior chamber.
Because of expansion of the gas.
There could be aqueous misdirection, Dr. Panda. In an instance like that, there could be aqueous misdirection as well. So I think the key is to look why the event happened and to control the pressure as much as we can initially medically with Diamox and IV Diamox and putting him on Diamox for a few days and finding out if the back of the eye looks stable and see how that breaks the attack. Completely flat AC is very rare. Would you be talking about a grade 3 shallow or like a grade 1 when this
it is almost plastered to the anterior chamber, to the endothelium.
Yeah, but I would think that
could it be due to the overfilling or
it was exactly not overfilling. He
or expansion
went up into the sky. It expanded, and by 3 days the inflammatory exudate caused an adhesion. So what we did in this case, we started the regime that you have advised. The next day the intraocular pressure is still 60 to 70. Then we removed gas from the vitreous cavity, and thereafter the intraocular pressure come down to around 40. The next day we reconstructed the anterior chamber, but still with full medication the intraocular pressure is still maintaining 30. So what you recommend? Will you go ahead for a incisional surgery or a bulb implantation?
So what was the indication for the vitrectomy?
The vitrectomy indication was retinal tear and vitreous hemorrhage.
Okay. So the next question is on gonioscopy, was the angle open after?
No, it is closed.
Completely closed?
Even with the slit lamp, it can be seen the iris is there over there.
Yeah, that's what I think this is happening because the angle is totally closed. So whatever you do, it's not filtering. Basically, there's no echoes going out. Yeah.
While doing the vitrectomy, was the AC formed or not is a question.
Yeah, at that time,
on that stage,
the patient was in completely stable condition, and then the patient was discharged.
No, what I mentioned is when we removed the extra gas on day 2 because the pressures are not coming down. Did the AC?
No, AC was not formed. Then we reconstructed the AC.
That is something that should have been a sort of the biomarker, if you want to call it that, before taking the patient off the table to make sure that the AC is well formed, and then figure out otherwise.
So you're suggesting that I think if you when we reduce some of the gas from vitreous cavity, the AC can be formed. It should be formed, yes. Okay, and that might restart the that may restart the kind of a exit through the trabecular meshwork and opens up the angle. So unless the angle is opened up, the pressure will remain kind of unpredictable. It will remain high.
Pushing, right? It's a pushing mechanism more than anything else.
Okay.
Correct, and that's what I said. Aqueous misdirection is
the gas has been removed.
So taking out the gas alone is not enough.
I think once there's a gas or silicon oil in the eye, I think you will tend to kind of think that there might be something to do with that, but the volume in the posterior posterior segment. But sometimes, like you are saying, sometimes we do see there's no gas in the eye, there's no silicon in the eye, vitrectomized eye, and that can develop a shallowing AC, high pressure. Picture something like aqueous misdirection. Yeah.
Correct. So
Yeah.
it's more
Now,
of a core vitrectomy
in
than
this
core
case,
vitrectomy.
there is no remnant of the vitreous on the posterior capsule.
Actually, I have seen that. I think what Dr. Bhattacharya is saying, I have seen that once happening. This was a repeat vitrectomy and complete vitrectomy. In fact, it was done for malignant glaucoma itself. So patient had aqueous misdirection, and usual treatment was done, including vitrectomy. It didn't resolve, and we did repeat vitrectomy with make sure that all the there's no vitreous left in the pars plana area anywhere, and the AC is still shallowed, and there's still secondary angle growth was still there. So eventually that patient had needed a tube implant. But here, because there's a gas in the eye, so we put a tube implant, the gas is going to out. So the purpose
gas we have removed now.
have removed. I think gas is removed, the pressure is still high, then probably you can put a tube in the behind the iris. I think if there's no silicone or no gas, then I think that is a little easier situation. But if there's silicone oil in such eye, or if you still need the gas, and then there would be a difficult problem, because sometimes it happens. I mean, iris just lens diaphragm just doesn't go back. Iris just doesn't go back.
I think the first thing you think about when AC is so shallow, I think everyone will agree with me that you're looking at an aqueous misdirection. That should be your first sort of diagnosis, and then work backwards from there. How do you break the aqueous misdirection?
Thank you
There
very
is no
much.
LPI when you're doing the gas, do a
Now,
PI.
PI was not possible because it's only
No,
stucking.
that's what I said. So with the vitrector,
Yes.
you can actually cut and make punch a hole from inside, from back to front. Right?
Yeah, the case I'm referring to, we did the iridectomy with the zonulectomy, we did the hyaloidectomy, rather actually vitrectomy in the first part with all these. It didn't work. I mean, it worked for initially, and again it got shallowed. And then we did complete vitrectomy, and still it came back.
I remember in every Prasad, there was one patient, you did all this, and the patient had to be permanently on atropine, and that wasn't a possibility. So we would stop the atropine, and again it would go back to aqueous misdirection. So finally needed a tube.
Yeah, so I think our patient also ended up with a tube. In that
Thank you very much.
situation.